Pain management. Pain is purely subjective. It is whatever the person that experiences the pain says it is, and it exists when he says it does. No two individuals will experience pain to the same degree. Each client has physiological, sociocultural, spiritual, and psychological factors that influence reactions to discomfort and pain. If clients are having difficulty expressing pain, it doesn't necessarily mean that they are not in pain. Pain involves the physical, emotional, and cognitive components. The Joint Commission Pain Standard requires healthcare providers to assess all clients for pain on a regular basis, and it is considered to be a vital sign. So when you get blood pressure, heart rate, respirations, oxygen saturation, temperature, you also need to be asking what the pain level is. A client that is experiencing pain cannot discriminate between these four factors of pain physiology. Transduction is thermal, chemical, or mechanical stimuli that causes pain. Energy of these stimuli are converted to electrical energy. Then when cellular damage occurs by thermal, mechanical, or chemical stimuli, neurotransmitters such as prostaglandin, bradykinin, potassium, histamine, and substance P are released. These substances surround the pain fibers in the extracellular fluid and then spread the pain message that causes an inflammatory response. Transmission. During transduction, the pain-producing stimulus will send an impulse across a sensory peripheral pain nerve fiber or a nociceptor. Perception is the point at which the client will experience the pain. No single pain center exists in the body. Modulation is the inhibition of the pain impulse. There are three other causes of pain that have been identified. One of them is the gate control theory that suggests that pain impulses will pass through when a gate is open and then are blocked when the gate is closed. The gates in the central nervous system can be physiological, emotional, or cognitive processes. For example, touch, massage, or a TENS unit. Physiological response will occur when pain impulses ascend the spinal cord toward the brainstem and thalamus. The autonomic nervous system, or the ANS, becomes stimulated. Pain will then trigger that fight or flight reaction of the general adaptation syndrome. Stimulation of the sympathetic branch of the ANS will result in physiological responses. If you look at table 43.1, it may help explain that a little bit better for you or clarify it. It will be important to remember that a client that is in pain will not always experience a change in vital signs. Behavioral responses to pain are going to vary. If pain isn't treated, the client's life will be altered. It interferes with every aspect of that person's life, supporting why effective pain management is essential. Pain threatens a client's physiological and psychological well-being. Acute or transient pain can threaten a client's recovery by resulting in prolonged hospitalization, complications from immobility, or delayed rehabilitation. Chronic episodic would be something like arthritis, headache, low back pain, or peripheral neuropathy. It's usually non-life-threatening, and it leads to psychological depression. It is unfortunately a major cause of disability. Cancer pain is usually caused by tumor progression and related pathological processes, invasive procedures, toxicities of treatment, infection, and physical limitations. And inferred pathological process is abnormal or damaged pain nerves. The attitude of the healthcare provider is very important when dealing with the patient's pain. It's important that the nurses and client's perception of the client's pain are congruent so the client can experience pain relief. If clients do not have objective signs of pain, some healthcare providers don't believe that the client is actually experiencing pain. Nurses allow their misconceptions about pain and pain management to interfere with their ability to treat their clients. Pain is a complex and holistic approach, and pain is complex, and a holistic approach to treating the pain may be helpful. Excuse me. With physiological, age will influence the pain experience, especially in the young and the very old. These two groups are not always adequately able to express their needs. Fatigue can increase the perception of pain and can cause problems with sleep and rest. The genetic makeup may possibly affect a person's pain threshold or their ability to tolerate pain. Any factor that interrupts or influences the normal pain reception or perception, such as a spinal cord injury, peripheral neuropathy, or neurological diseases, can affect the client's response to pain. Socially, attention to pain, previous experiences, and social support systems are going to help affect pain experiences. Repeated pain experiences may help the client deal with the present pain experience. A client often relies heavily on others for assistance. Spirituality stretches beyond religion. The client may ask, "Why am I suffering?" Or "Why has God done this to me?" Psychological anxiety will increase the perception of pain, which causes more feelings of anxiety. Excuse me. It's difficult to separate pain and anxiety sensations at times. Critically ill and injured clients often perceive a lack of control over their environment and experience high levels of anxiety. Coping styles influence a client's ability to handle pain. For example, allowing the client to self-medicate using a PCA can help the client control the pain experience. And then cultural can definitely affect the expression of pain. It's important to remember that people do not respond to pain the same way. Successful pain management is going to depend on establishing a relationship of trust between the client, family, and healthcare providers. Clinical guidelines are available to manage pain from the American Pain Society, from the National Guidelines Clearinghouse website, from the Sigma Theta Tau International website, and the American Nurses Association certification exam. When you're assessing pain, the American Nurses Association believes that the pain assessment and management is within the scope of every nurse's practice, and this is why pain is now known as a vital sign. It really is of paramount importance to ascertain the level of pain the client is experiencing. It's also important to encourage the client to express pain or discomfort. Encourage them to not let the pain become too severe. It's also the nurse's duty to constantly assess the client's pain. When a client has an injury or, for example, has had a surgical procedure, we expect the client to hurt when they move, but we are hoping that the pain will subside following a few minutes of relaxation. So basically, we encourage the patient to not allow the pain to become too severe, because then it can take higher doses of pain medication and it can take longer for the pain medication to work. We also encourage the patient to ask for pain medication when they're beginning to feel twinges of pain, but to understand that when they move, it's going to hurt, and they don't need pain medication every time they move. They give it a chance to subside, and then if they're still hurting after a few minutes of relaxation, then pain medication is appropriate. We look at different symptoms of pain, such as verbalization. They're grimacing or crying or moaning. They splint the painful site, such as this picture on your slide. Their vital signs may have increased. They become restless. Older adults may become confused. They may have some nausea or vomiting or even some diaphoresis. And these are just a few of the symptoms. In box 43.9, there's various behavioral indicators of the effects of pain. So then we look at the characteristics of pain. Again, don't let the pain become severe. We do expect the client to hurt with movement, but the pain should subside with relaxation. When you are assessing pain, remember the PQRSTU method. P being palliative or provocative factors. What is going to make it worse and what makes it better? Quality. What is the quality of pain? Can you describe it? Is it sharp? Is it achy? Is it burning? Is it stinging? Etc. Where is the region the pain is in, and does it move anywhere, or does it radiate to another area of the body? Severity on a scale of 1 to 10. Time. How long has the client been experiencing pain? When did it start? What were they doing when it started? And you. How is pain affecting you, the client? Careful assessment is going to reveal the presence or potential for pain. Assessment and selection of appropriate nursing diagnoses will lead to appropriate nursing interventions. Pain is not always completely alleviated. We do promote rest along with the ability to complete ADLs. And then the concept map. We know that nursing processes are interrelated and linked to the client's medical diagnosis. For example, for rheumatoid arthritis, we can have diagnoses of acute pain or impaired physical mobility or dressing and feeding self-care deficits or fatigue. We look at all different types of interventions, but pain therapy requires an individualized approach. Non-pharmacological and pharmacological approaches can be utilized. Each one of these techniques can be used in combinations. You do need to understand that a TENS unit or acupressure does require a physician's order. Now, not all therapies are going to be beneficial or liked by all clients. And remember that the simplest act can reduce pain, such as smoothing a wrinkled sheet, or repositioning a client, or positioning tubing away from body surfaces. Clients need to be able to participate in relaxation, guided imagery, distraction, and music therapy. So keep that in mind if that's something that you do recommend to the client. Biofeedback is another type of non-pharmacological intervention. During a biofeedback session, electrodes are attached to a client's skin, and these electrodes or sensors will send signals to a monitor that displays a sound or a flash of light or an image that will represent the heart and the breathing rate, the blood pressure, the skin temperature, sweating, or muscle activity. So when a client is under stress of pain, these functions are going to start changing. So the client will see these stress responses as they happen on the monitor, and then they get immediate feedback as they try and control those responses. These sessions are typically done in a therapist's office, but there are computer programs that connect biofeedback sensors to your own computers. The client uses several different relaxation exercises to help control these biological responses, such as the imagery or progressive relaxation, etc. Complementary approaches are going to include basically the non-pharmacological interventions that are listed, in addition to spinal manipulation, yoga, glucosamine and chondroitin, heat or cold, and again, all of these other non-pharmacological interventions. Non-opioids will include acetaminophen and NSAIDs. Acetaminophen has no anti-inflammatory or antiplatelet effects, but it does have an effect on the liver, and its exact mechanisms of action are not really known. NSAIDs are non-steroidal anti-inflammatory drugs such as aspirin or ibuprofen, and these provide mild to moderate pain relief. Most NSAIDs will work on peripheral nerve receptors to reduce transmission of pain stimuli. Chronic use is associated with GI bleeding and renal insufficiency. Opioids are prescribed for moderate to severe pain. These are associated with the CNS depression, the central nervous system depression, hypotension, respiratory depression, and adverse effects of nausea, vomiting, constipation, itching, urinary retention, and altered mental processes. If you look at box 4313, it has information regarding principles for administering analgesics. Adjuvants and co-analgesics are drugs that are used to treat other conditions, but they also have some analgesic qualities, such as tricyclic antidepressants or anticonvulsants. These can be steroids or sedatives, anti-anxiety and muscle relaxants. They have no analgesic properties, but they can also potentiate effects of analgesics. Again, side effects will be drowsiness or impaired coordination and judgment, decreased mental alertness, and can also lead to respiratory depression. A PCA, which is a picture of what is on your slide, will help clients manage their own pain, but the client has to be able to participate in this type of intervention. We really caution the family not to push the button for the client. It does require a mainline IV fluid, but it can just be a to keep open rate. The most common types of drugs used in the PCA are morphine, hydromorphone, and fentanyl. Local and regional anesthesia are used in a variety of conditions, including labor and delivery, chronic cancer pain, and selected postoperative procedures. It includes blocks of specific areas, epidurals or spinals, which may be continuous infusion or intermittent injection, and perineural infusion pumps, which are pumps that have local anesthetic placed near a nerve or group of nerves in a surgical wound. I've seen these most often in shoulder surgeries. With the epidural or spinal analgesia, these are intermittent injections or a brief infusion, and vital signs have to be obtained every 15 minutes. With continuous infusions, once the client has stabilized, vital signs can be obtained about every 2 hours. There's topical agents such as EMLA, and lidocaine, and these are administered through patches or discs, and they produce anesthesia to soft tissue. When you administer pain medications, you are responsible for monitoring the client for effective pain relief as well as potential adverse reactions. You should have on hand medications to reverse the effect of pain medications, such as Narcan. Many facilities have a kit that is pulled and kept with PCA pumps or continuous epidural infusions. And you will also need to monitor IV insertion sites, lines, and IV controllers to make certain that the proper amount of medication is being delivered. Vital signs should be obtained at least every 4 hours with visual monitoring of the client more frequently. And be aware of specific complications and side effects of the analgesic that's being used. Always check with your healthcare facility for policies and procedures. When monitoring chronic non-cancer and cancer pain, we have to realize that cancer pain can either be chronic or acute. It follows the Agency for Healthcare Policy and Research, or AHPR, guidelines that treat cancer pain very comprehensively and aggressively. Estimates for addiction to pain medication for this type of pain range from 1% to 24%. Excuse me. Clients that have chronic pain need to be given medications on a regular basis. The World Health Organization recommends a 3-step approach to the management of cancer pain. The treatment will begin with NSAIDs or adjuvants and then will progress to opioids. Transdermal and transmucosal fentanyl. The transdermal is 100 times more potent than morphine and can provide analgesia for 48 to 72 hours and is commonly used for chronic pain. The client that is receiving the fentanyl patch has to be opioid tolerant. They have to weigh over 100 pounds and they cannot be hyperthermic. If you are applying a patch to a patient who is feverish, it causes the medication to be released faster. The transmucosal fentanyl will exist for the breakthrough pain. The client, healthcare provider, and healthcare system problems with addiction is going to alter the use of medication. Box 4316 has barriers to pain management. Physical dependence, addiction, and drug tolerance. Physical dependence does not imply addiction, but rather it's a state of adaptation that's manifested by a drug withdrawal syndrome. Drug tolerance also does not imply addiction. Instead, tolerance is the diminution of one or more of the drug's effects that result from a repetitive use over time. So in other words, the longer a client uses a medication, the more chances they have of becoming tolerant to the medication, so it just does not work the same anymore. Addiction is actually a neurobiological disease that's influenced by genetic, psychosocial, and environmental factors. The ASPMN position statement says that patients with addictive disease and pain have the right to be treated with dignity, respect, and the same quality of pain assessment and management as all other patients. And then placebos. Placebo administration is considered unethical and deceitful. In other words, it should not be done. Programs for pain treatment. Pain centers treat clients on an inpatient or outpatient basis. The goal of palliative care is to learn how to live life fully despite the pain. Hospices are programs for end-of-life care and focus on quality over the quantity of life. They provide aggressive treatments for pain. The client's response to pain may not be obvious. Their responses may be sleep. It may be a visible relaxation of the body and facial features. It may be decreased restlessness, elevated vital signs that have now returned to normal, nausea or vomiting that now ceases, or the client begins to interact with those around them. But again, it may not be obvious. Evaluating the appropriateness of pain medication requires the nurse to evaluate the client 15 to 30 minutes after administration, depending on the route of administration. Evaluate the client's perception of the effectiveness of the nursing intervention. Utilize the same pain measurement scale with the same client if you want to be more accurate.